what the other types of assessments do is they help us to pinpoint, or at least to narrow our field of possibilities towards a specific diagnosis. So if someone comes in with a cough, you have to ask particular questions. Well, what kind of cough is it? Is it a croupy cough? Is it a loose cough? Is it a dry cough? Is it a cough, 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 cough? Depending upon the kind of cough it is, that might clue you into other ideas. So we're using history and physical signs and symptoms as a way to generally make a broad diagnosis about 75% of the time of what we're dealing with. From there, we tend to make a general assessment to try to help us to narrow down the possibilities. And we do that with the tests that we do, and we actually put our hands on the patient. We do inspection, auscultation, percussion, and palpation. And those things tell us other things to kind of pay attention to. And as we're narrowing down our possibilities, it might include laboratory data. And laboratory data helps us specifically to confirm our suspicions. So if we've got a diagnosis 75% of the time based upon what they say alone, we start to do a physical assessment, and then we do laboratory assessment. We can usually make a pretty strong case, because a diagnosis is based upon a preponderance of evidence. The evidence are all the things that you gathered: the signs and symptoms, the history and physical, the laboratory data, the chest x-ray. And so you make a diagnosis based upon this and this and this and this and this, and you've got this litany of tests that help you to confirm your suspicions. So we're going to talk specifically about laboratory assessment and how that helps us to confirm our suspicions. But the thing about laboratory tests is that you always have to evaluate the test in light of other findings. And so I heard a talk at the beginning of the academic year from a medical lab scientist who does thousands and thousands and thousands of tests in New Mexico. He runs a lab, and he's talking to us, to the faculty of the College of Health Professions, specifically about how we do how we're moving towards population management, and how certain diseases are common, or certain conditions are common that are treated with these specific tests, and these tests then put patients on specific medications to treat those diseases. So he made an argument for relating the patient's normals to the patient's normals, not necessarily a high or a low range, because that's what we do in healthcare, is that we say your sodium has to be within this range, your potassium has to be within this range, your magnesium has to be this range. And so we're creating high and low values, and if you fall in the middle, that's normal, right? But he's making a case about making sure that we recognize that there are totally healthy, normal people who fall outside of these ranges that we've created. So we have to understand that in light of laboratory tests. So they're always evaluated in light of other findings, that normal patients may have abnormal results. You can get a sodium of 150, and that's normal for that patient. They always run 150. But if you're trying to treat a patient that's, and what is it if you have high sodium? What's that called? Hypernatremia, yeah. Hypernatremia, you try to treat them with a diuretic, that may throw that patient off whatever they are considered normal. So you have to consider your values for you, not necessarily your values for what the lab has decided is high and low. And you'll see that those values are different in facility to facility. If you go to the U of U, or you go to Salt Lake Regional, or you go to Altaview, or you go to any of these hospitals, they'll have their own, corporation-specific values that are within the high and the low, normals, whatever they consider to be normal. So we have to remember that normal patients can have abnormal results, and normal patients can have abnormal results. Okay? So we kind of have to use the data in light of all the other findings and recognize that we can fall inside and outside of those norms. One of the first things that respiratory therapists notice is abnormal secretions. So we specifically pay attention to the kind of cough that a patient has, whether it's a loose cough or a productive cough, and if it is productive, what it's productive of. If it's thin, white secretions, then we can't necessarily associate bacteria or viral organisms to it because it's clear. But it starts having color, and we start making decisions about what could possibly be an organism that we could maybe treat. So sputum collection, sputum analysis, it begins with the kind of a cough, the consistency, the amount. Sometimes in cystic fibrosis cases, they'll actually measure, some places do, I've not seen this, but some places will measure the volume of the secretion over a 24-hour period. Like when they're in the middle of an exacerbation, they might have 20 milliliters in a 24-hour period, and that will be characterized over time if it's higher or lower. But then again, you compare it to the patient's normal. So abnormal secretions, color, consistency, if there's a particular smell to it, all of that stuff is meaningful, relevant information. Okay? If you can attach it to particular pathologies. If it's particularly purulent, we might look at a bronchiectasis characteristic, a bronchiectasis diagnosis, and then we get a chest X-ray and we notice saccular bronchiectasis. Have you looked at that on an X-ray yet? Mm-hmm. Let me just show you, just so that you have an idea. So I want to bring up some pathologies while we're doing this. Bronchiectasis. So some of these. So in this chest X-ray, turn off some lights. In this chest X-ray, you can see that there's some specific areas in the terminal bronchioles that are particularly filled with purulent secretions. You can see the bifurcations. So the surrounding parenchyma is open, it's full of air, the alveoli are open, but the airways themselves are full of mucus and secretions. So in this case, bronchiectasis, all of those, you can kind of see the tracheobronchial tree as it goes through essentially throughout the lung fields. Well, that would have a particular kind of secretion. And so if they have thick secretions, yellow secretions, it can actually change the morphology of the tissue. So what happens with a patient like this is that they have a particular cough, they report, and it's documented in the history that it's been ongoing for a year or 2 or 3 or more. What's the difference between acute bronchitis and chronic bronchitis? Yeah, acute is less than 3 months. Chronic becomes 3 or more months, 2 or more years of a productive cough. So you're coughing secretions continuously for 3 months, 2 consecutive years. And then that chronic bronchitis turns into a bronchiectasis, and now you've got serious complications that haven't been properly treated up to that point, and now you've got airways throughout the tracheobronchial tree that are full of mucus and secretions, and it's particularly odorous. There's a smell to it, and it becomes very particular. But again, it's another piece of evidence that leads you to believe that this is bronchitis and not just a bronchiectasis and not just a simple bronchitis. So you take it in light of all the other evidence. So that's bronchiectasis. Let me look at saccular bronchiectasis. is there are different types. And if the airway is full of mucus and secretions that long, eventually you'll get particular types of bronchiectasis. The first type, bless you, the first type is just fusiform. So the airways will be dilated and you'll see little bulges in the airway. That's called fusiform bronchiectasis. Another type is cylindrical, where the whole airway, this might be, you might be able to classify that as cylindrical. It looks like just all of these airways in here are cylindrical. That it's a cylindrical shape. It's not fused. It doesn't bulge and then come back down. It's more cylindrical throughout. Or the last type, saccular bronchiectasis. And that's literally what you're seeing with saccular bronchiectasis. Is that it changes the morphologic structure of the airways because of long-term chronic infection that would lead us to believe that that's what we're dealing with, is a particular kind of bronchiectasis from long-term secretion production that hasn't been adequately treated. This takes years to get to, but that's essentially what happens, is you end up with mucus in these saccular, morphologically changed airways that develop secretions that can't be treated.
So those are the alveoli that are like...
That's the airway. So the alveoli are microscopic. You can't even see the alveoli. Those are the airways.
Okay.
Yeah. Let me see if I can get you a better picture.
That's a good picture.
That's interesting.
I think there's one in the book too.
Yeah, there is a really good one in the. So here's cylindrical. See how the airways are just bulging out and that kind of expanded. That's probably the. Let's see, it's probably the left lower lobe. But it's cylindrical bronchiectasis.
Is this looking from the side?
I think it's an AP view. AP view.
Because you see the shrink.
Yeah, exactly. It's kind of spine. So this is cylindrical bronchiectasis, and what page is the?
229.
Yeah, take a look at 229. Saccular bronchiectasis.
30.
Oh yeah, that's a really good one right there. Go
So
ahead.
with all these different kinds of airways, would it be painful to breathe?
No, it doesn't. There are no pain nerves
Okay.
associated with the lung parenchyma. So the lungs don't feel pain themselves. The pleura does. The visceral, I imagine the visceral pleura as you pop through the pleural space would be a little painful. But the lungs themselves, you wouldn't feel pain associated with this kind of pathology. So you can see that the lower parts are filled with mucus and secretions. But those are the airways. Those aren't the alveoli. The alveoli are smaller than that, right?
So the airways itself then.
So, but the mucus and the secretions would be particular in this kind of an infection. You'd have purulent, loose cough, yellow in color, and it would be specific. So you take it in light of all your other findings. Go ahead, Anna.
So does it typically only get that bad if you have like cystic fibrosis?
Could be, but it could be without cystic fibrosis too. But the point is it's a long-standing chronic infection that's allowed to get to that point. They haven't sought medical care for sometimes years.
Okay.
How
And
would they, I don't know, I'm just like wondering,
how do people function that way?
yeah, how do they just deal with it?
They get by and they minimize their symptoms. They don't seek medical attention because it's not, because they do this every day. They get up in the morning, they'll cough, 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 they'll get some mucus out, and they'll go about their daily routine and not.
Most of the time, is it because they're aware something's wrong, but they just don't want to
Perhaps, yeah, they don't.
Or yeah, they can't
They can't afford
afford it.
it. Yeah, that's an
Or they're
issue.
scared.
Poverty is a huge
Yeah.
issue.
Yeah.
So they don't take care of it. They don't seek medical treatment, and months turn into years, and pretty soon you've got a morphologic condition that has secretions that are just, horrendous, that they don't seek medical attention. It's sad. It's sad. But that's the extent to which you know, your assessment can, you're putting together signs and symptoms and physical characteristics and rationale for why people don't get health care, why they don't seek medical attention, and it's all of those reasons. And it's probably as different for the patients as it is for the kinds of people that we see with bronchiectasis. I can't say that I've seen a lot of bronchiectasis, but it's out there, and it does happen on a daily basis across the United States. So, but the secretions are particular, and what I'm trying to do is show you a group of, you know, at least the secretion analyzation that helps us to make a diagnosis. So we start out with an inkling that, you know, maybe this is a cystic fibrosis, and that the patient reports that there's no cystic fibrosis. So then we start looking for a reason for all of these secretions, and the purulence of the secretions, the color of the secretions, and what it might lead to as far as a diagnosis. So everything's a possibility. The more things we start to find, and then we get a chest x-ray that looks like this, oh, this is saccular bronchiectasis or cylindrical bronchiectasis. Okay? So we can do sputum samples, we can do nasotracheal suctioning to get secretions. What other diseases might come out of lots and lots of secretions? What if a patient has a bit of a blood-tinged cough? What's that called? Hemoptysis. That's right, hemoptysis. So if they have hemoptysis and they end up with a chest x-ray that looks like this,
Tuberculosis.
you get something like that where these bacteria, we might do a sputum examination. We're looking for an acid-fast bacillus. And that acid-fast bacillus helps us to make a diagnosis that this is tuberculosis. Or the other name for this is a Zeal-Nielsen test. So if you see anyone in the hospital, you know, they're collecting Zeal-Nielsen specimens, they're looking for the tuberculosis bacillus. So a Zeal-Nielsen is a tuberculosis. But tuberculosis, what we know about tuberculosis is it's an oxygen-loving disease. And so it tends to form in the upper lobe of the lungs. In the apical segments, we'll find in A&P that the oxygen level is higher in the apical segments, it's lower in the bases. So oxygen is higher, the bacteria tends to go higher in the apical segments. This is systemic throughout, but in most cases of tuberculosis, you'll see that it particularly congregates in the apical segments. Let's see,
And then
this
the other side
one.
over on the left side? Or
No.
See how that's kind of staying up in the apical
I
segments.
mean, that makes sense. It's more, it's more oxygen.
Okay, so there are, these are causing, looks like a bit of a pneumonia. You can see that there are bigger patches of white diffuse infiltrates in the apical segments caused by tuberculosis, less, and none really in the bases of the lungs. But this has caused a pneumonia. This is a tuberculosis that's transpired into a pneumonia up in the apical segments because of that diffuse hazy infiltrate up there. So the fact that they have a little bit of hemoptysis makes it particular to look at certain types of illnesses, certain types of diseases. And that hemoptysis then leads us to believe there are certain causative organisms. And it's not bronchiectasis. This one, because of the characteristics and the chest x-ray, then helps us to look for a definitive diagnosis. So all of these pathologies are based upon a clinical observation, a clinical assessment using all of our knowledge about what's particular and unique about each of these illnesses. In tuberculosis, we can sometimes do gastric suction. We can take secretions out of the stomach. Why would we do that? What's that, Jimmy?
Swallowing there.
Why would you take secretions out of the stomach to analyze for tuberculosis?
They swallow.
Yes, exactly. That's it, Kyle.
Stuff.
They swallow their secretions. We have 2 centimeters through this the mucociliary escalator, and we always swallow that. it's a normal thing. There are a few people that spit it out. I think that's gross, but normally, physiologically, what we do is we swallow those secretions. So if a patient can't produce a cough, we could go down into the stomach and suction out the stomach and get secretions that we could analyze specifically for tuberculosis. Tuberculosis, we do it 3 consecutive mornings, usually. So we'll do 3 tests, Zeal-Nielsen or the Zeal-Nielsen or the acid-fast bacillus we'll isolate it 3 consecutive mornings. So if it's done 3 times on 3 mornings and we isolate tuberculosis, that's what they've got. If they only isolate it 2 of the 3, then it's inconclusive. Okay.
So then would they just, what would you do? Would
They
you do
call it a
again,
negative
or-
test. They might take precautions until they rule it out completely. Yeah. So nasotracheal suctioning, gastric suctioning. Occasionally we'll go in and we'll do secretions from a bronchoscope. So we can go in through the nose, the oropharynx or the nasopharynx, and go back to the back of the throat and go down into the airway with a bronchoscope. Have you seen that? The bronchoscopy? Maybe I can show a YouTube of a bronchoscopy. Another way we can get abnormal secretions is through a transtracheal aspiration. So you go through about the first, below the thyroid cartilage, the next one's the cricoid cartilage, and you could pop a needle through the cricoid cartilage and get sterile secretions. So the only reason why you'd go in with a needle aspirate for secretions is to get a sterile sample. Everything else isn't sterile. And we can't rely on the results from a non-sterile sample. So, but patients don't like this so much. They don't like being asked. They don't like needles through their cricoid ring.
Weird.
I don't know why, but
How's that feel?
they'll numb it up with lidocaine. You probably wouldn't even feel it other than pressure going through
Mental,
that
like,
cartilage.
knowing
So that's show you how to breathe
Imagine that, Weird.
So this is just a short.
Paul,
Yes.
when are we gonna go to lunch?
About 12.
Thank you.
So what they're doing is I can make this larger. What they're doing is they're nebulizing, not a bronchodilator, but they're nebulizing a lidocaine. No, that's an IV. So they're starting an IV in the back of his hand, just to give him fluid if he needs it. If he drops his blood pressure, they can give him fluid. But they're nebulizing lidocaine, and that lidocaine then is numbing up the back of his throat. How many liters of a cardiac output do most of us have? About 5 liters. So sometimes with patients get exposure to these medical procedures, they'll vasodilate and their blood pressure will fall. So what you can do is start a bit of fluid and circulate that fluid in your vascular system to help to maintain blood pressure.
Feel like it was nothing.
Like
Just
this.
boom.
We're going to show lots of
Stuck
neat
it in
stuff.
way fast.
Look at all that blood.
Getting some blood tests.
See, that would be awesome if you came out with.
This one altogether is only like about 9 minutes. So. But it's essentially the procedure he's explaining is procedure. I can editorialize. So they'll put on a pulse oximeter to measure his oxygen level. But what they're going to do is go through his nose or his mouth and go back to his oropharynx, go through his vocal cords, and take a look at the tracheobronchial tree. So why would you do a bronchoscopy? What's the assessment reason for doing a bronchoscopy? And therapists, by the way, they assist with a physician. What's the anesthetic that they use? Anybody know? Yes, they do, Jimmy. You knew that. How did you know that, buddy?
I read it from one of
Okay.
We're just
Well,
saying.
We'll take your word for it.
What's it
So
called?
they'll put cotton balls full of cocaine, maybe 1%.
Okay.
1% cocaine, but what does the cocaine do? It numbs it, but it also vasoconstricts the vessels so that they tighten up so they don't bleed. That's the purpose of putting cocaine in their nose. It causes vasoconstriction and they don't bleed.
Oh,
because it's more than
Yeah.
I don't know where I went.
You know what I'm saying?
Yeah.
From the lab
Exactly.
business.
I'm just teasing.
Yeah.
How do you know?
You know,
Jimmy,
okay.
it's rad. It's fine.
Oh.
Jimmy uses cocaine medicine.
So it's going through his nasopharynx, it goes back through the turbinates, through the oropharynx in the back of the throat, there's the
Ew.
nose. That's the
Look at those
vibrissae. Those are the middle turbinates,
It's a good name right there.
superior, middle, and inferior.
What's
That's
that?
all I know what's going
That's
We're
the,
hitting something.
on. We're not getting.
Must get through.
so when you do suctioning, you gotta go past those structures.
Oh, nose hairs.
They did, they're going down the other nostril,
I hate
the other
this.
nostril.
What was that though that it was hitting?
Probably just a bulge in the posterior
Oh my gosh.
turbinate.
I've had my nose scoped and it hurts.
And he's totally awake.
Yeah, it is, but he's numbed up, he's being monitored with an oximeter and probably blood pressure monitor.
How is he not?
You
So remember when you suction too, it's like
There we
a
are.
bronch. So there's the epiglottis, right? This right here. There's the epiglottis, there's the vocal cords.
Looks like a monster.
It does.
That's what I thought. And then you'll go.
So the reason you do a bronchoscopy is to see what the hell's down there. If you've had a cough, if you've had congestion, if you've had chest pain, sometimes they'll go down and do a biopsy, take a sample from the upper airway or the lung. So there's the arytenoid cartilages up on top, right? So if you're intubating this patient, you're looking for the arytenoid cartilages. So he's making a sound so you can see the vibration of those
Whoa.
vocal cords.
Yeah, you see what people sing, it's crazy.
Yeah.
you
Yeah,
see
it's crazy.
Aerosmith.
Yeah.
Oh.
Steven Tyler.
Did he
Discovery
put something back in his nose?
Yeah, they measure his vocal cords.
Doesn't he like pop his capillaries all the time? So I have to always go in there
You
and
might.
like seal
Right.
them. I don't know. That's
For
why.
as long as he's been screaming.
Yeah, I think
your
he
lobes.
said something like they do that almost.
See the bronchi.
That's
I
crazy.
wouldn't be surprised.
Like,
So those are the cricoid rings. Those are C-shaped rings down the trachea. And the carina down below, you can see where it splits to the right side and the left side.
This is cool.
There
There it
There's
is.
the carina.
There's the carina.
So it splits to the right and the left side, but you can still see
It's so big.
the C-shaped rings in there.
The magic school, I know.
There's the right upper, right middle, and right lower. That's
Look
how
at all
fast it
those.
All
splits.
those
Wow.
lobes?
Yeah.
Whoa.
Those are
Uh-oh.
sub-segmental bronchi.
We got some secretion.
Some bubbles.
Oh yeah, we do.
Whoa, it's so crazy.
Wait, so how far would they? How,
They're only about 5 or 6 generations. That's as far as you can see with a bronchoscope.
that's as far as you want to go.
crazy.
Yeah.
Like
5 or 6 generations. What does that tell you about the rest of the lungs?
Tiny.
If you can go another 20 generations, they dichotomously branch 20 more generations.
I wanna see more. That'd be so sick. Magic school.
What's the teacher's name?
Mrs. Frizzle.
Frizzle,
Yeah.
Mrs. Frizzle.
The one
Miss
with the
Frizzle.
iguana?
What they're doing now is a brushing, so they're taking cells from the lining of the tracheobronchial tree with that brush.
Oh!
Oh, how
They'll
does
put
that?
those
That's
on a
all
microscope
that-
and they'll take a look,
Well, you don't
see if
feel
there are any
anything there.
abnormal cells.
No.
Yeah, no pain. That patient might feel some pressure, but
Oh, what are we doing now?
We're taking part of the
It's
wall.
the claw.
another thing that they'll do is they'll take a
No,
chunk.
they look inflamed now.
See,
right there.
see how it's like a jaw, and so they'll take a bite and then they'll pull it,
What?
and
Yeah.
just to take a tissue sample.
Really?
Oh.
Oh!
That's a big one. That's a big one.
Stop it.
Oh,
Oh.
it stops right
The
there.
aftermath.
Is that the Carida?
No, that's.
No, that's really
Down.
Bill,
Deep.
oh.
Why would this guy go through this like just willingly?
For science.
Yeah.
Science,
I would
man.
too.
Just film
Science
how fast
rules,
you
Oh,
go.
For
okay.
science, probably.
Ah,
You know
how many times do they do it?
They'll, 2
How
or
many
3.
seconds does it take? Okay.
Like, I
And
really
then
did.
what will they put on the side to
God,
stop
they're
the
like
bleeding?
cutting out chunks.
That's a big
What would they put on the side to stop the bleeding?
Cocaine.
Not cocaine. just like-
Everyone cocaine. That's all we remember.
Yes, it is. It sure is. It's epinephrine.
Epinephrine.
So epinephrine causes vasoconstriction and stops the bleeding.
Didn't.
Yeah. They'll just squirt epinephrine on the top of that blood, and it'll cause the vessels to
So
constrict.
we'd be assisting a pulmonologist.
Yes, you will.
To do this.
Pulmonologist. That's so.
We just been
That's
watching
right
their
there, that's right
sats
there.
and stuff.
Nuts.
Wait, the respiratory therapist on the right,
Yeah.
and then the pulmonologist.
Sorry,
Yeah.
this is the guy with the
And,
scope.
and as students, if they do a bronchoscopy, they'll usually show, they'll have, rather than, this has a camera at the eyepiece, but then the camera usually sets up now to a video screen that you can see it while they're doing it.
While
So
you're
they,
in there.
you might get a chance to do a bronchoscopy.
There's those guys. There's those students' names again.
Yep, so they're changing his partial pressure, giving him a little bit of
You'll need
oxygen,
my
right?
chunks.
He's probably numbed up a little bit, and just explaining what he felt, but I don't think it was painful, I don't think it was
That's so weird.
That's so cool.
hard on him.
That's legit.
So that's a bronchoscopy.
Why you laughing?
That's the real demon that is
You know, like I would say, like if I have to have it done.
Here's another few.
What?
I would just like, you know.
Yeah, where are we?